Well, that was pretty effective. Good morning. I'm Larry Eichel, Director of the Pew Charitable Trust Philadelphia Research Initiative. We provide nonpartisan research and analysis on key policy issues facing Philadelphia, including lessons learned from other jurisdictions. I want to thank all of you for joining us today. We're thrilled that you're here for what we think will be an informative conversation about a very important topic. Today's discussion about the opioid crisis stems in part from Pew's latest State of the City report. You can find a copy of it inside your packet or at pewtrust.org/State of the City. The report is our annual look at the key indicators of Philadelphia's condition, and this year we found that the numbers painted a pretty distinct picture. First, some of the major trends that have been transforming the city for the past decade or so are alive and well, such as Philadelphia's continuing population growth and rising immigrant presence. Second, the economic indicators are generally positive, at least relative to the city's recent past. In 2017, job creation and home sales were strong, and unemployment declined substantially. But the social indicators are unsettling at best, including a poverty rate that remains stubbornly high and a rising homicide count. And then there is the topic that brings us here today. In 2017, Philadelphia had an estimated 1,200 unintentional drug fatalities, mostly due to opioids, a total that has doubled in the last 3 years. And the death rate from drugs in Philadelphia is now among the highest in the country. We've assembled a stellar panel of experts to talk about what is being done, what can be done, and what approaches are showing the most promise in Philadelphia and other jurisdictions facing similar problems. Please join me in welcoming Dr. Thomas Farley, Philadelphia's Commissioner of Health, the Honorable Michael McMahon, the District Attorney of Richmond County, New York, also known as Staten Island, Evan Burley, Special Advisor for Opioid Policy for the Baltimore City Health Department, and Cynthia Riley, Director of Pew's Substance Use Prevention and Treatment Initiative. Cynthia joins us from Pew's Washington office, where she leads our efforts to develop and support policies to reduce the inappropriate use of prescription opioids and increase access to effective treatment throughout the country. Thank you all for being here. Today's discussion is being live streamed and live tweeted from @PewHealth, and we encourage those of you in the room and watching online to participate in the conversation using the hashtag #PewTalksOpioids. And now it's my pleasure to introduce our moderator, Maiken Scott. She's the host of WHYY's The Pulse, a national radio program and podcast that explores the people and places at the heart of health and science. Maiken has covered behavioral health and substance use issues for over 20 years, and we thank her for leading the conversation today. Maiken, it's all yours.
Thank you. Thank you so much. Good morning to all of you. I'm very excited to be here. Good morning to everybody on our panel. Just to give you the lay of the land briefly, we're going to jump right into our conversation, talk for about 45 minutes, answer some big questions, and then we want to hear from all of you in the audience. So we will open things up and pass around a microphone so you can address your questions to the panelists directly. All right, and I just wanted to remind everybody to check your phones and make sure they are on silent. I want to start with you, Dr. Farley, and it's been a year since the Mayor's Task Force has issued recommendations on what to do about the opioid crisis problem in the city. Could you tell us about a few areas where you think progress has been made and maybe highlight a few others where work remains to be done?
Sure. So for those people who don't know, the Mayor convened a task force that met over several months last year, issued 18 recommendations in May of last year in 4 general areas: prevention and education, treatment, overdose prevention and harm reduction, and then involvement of the criminal justice system. And I think it's fair to say in all those areas we made a lot of progress in putting policies and programs in place, but it's still too early to see how those policies and programs have made an impact, what impact they will have. We need to have more time for that and more implementation. So in the area of prevention and education, we've done a lot to educate physicians and deliver very direct messages about getting them to prescribe less. And we are just now putting in place some policies that have more teeth to that to reduce overprescribing. We've also educated consumers about, to try to get them to have a healthy fear of prescription painkillers. On treatment, not my area of responsibility, but we work in partnership with another department. They have done a lot to improve more availability of medication-assisted treatment, which wasn't routinely available here in Philadelphia. We've been working with them to make that form of treatment available in primary care, but we still have a strange mismatch where we have a lot of people who say that they want treatment. We have treatment availability, and we actually have a lot of empty slots. So somehow we're not yet figured out how to connect up the people who demand treatment with our treatment services.
And are we learning anything about what is the disconnect?
You know, that's not so much my area of expertise. I don't fully understand. I think we do have a variety of administrative hurdles that make it tough for people to get into treatment. It may seem minor to us, but maybe major to somebody who has to inject 4 times a day. You know, if you have to go through paperwork and have an interview today and you start your treatment tomorrow, that's too long. You know, so people want to have treatment on demand, where you walk in and within an hour you get your first dose of Suboxone. We're not there yet. In overdose prevention and harm reduction, we've done a lot to educate people about use of naloxone to prevent fatal overdoses. We distributed tens of thousands of doses. Too early to say whether it's really out there in everybody's pockets and everybody's using that. And then with the criminal justice system, the prison system here has done fabulous work to make treatment more available and to screen people for addiction while they're in jail. But that's really just beginning now. And that's an opportunity which I think is really great over the long term because so many people who are addicted cycle through the jail.
Yeah. That brings us to some next questions. D.A. McMahon, Staten Island, Richmond County was one of the first urban jurisdictions in this part of the country to really focus on this problem. Mm-hmm. What is your part of the puzzle in this, and where have you seen progress in your region?
Thank you, Mike, and good morning, everyone, and thanks for having me here to beautiful Philadelphia. So the problem and the situation on Staten Island was one where I think everyone was realizing that we had a terrible problem, and yet there wasn't really sort of a centralized or a main focus on it from government. And I was elected in 2015 in November and came into office in 2016 and immediately set about trying to put in place what we call a Marshall Plan approach to the problem. We did not have real-time data as to how severe it was, and the law enforcement's approach, public health's approach was still not quite as engaged as it should be. Quick anecdote, between the time that I was elected and I came into office, a young man right on my street collapsed in front of his parents' house in the middle of the night and died from an overdose, heroin overdose. He was 22 years old, and I knew him since he was a young child, watched him grow up. So when I came into office, the first thing I said was, bring me the file on the investigation of the death of that young man. And I was surprised to learn there was no investigation. It was closed because it was considered an accidental death, and nothing was being done. And so I sat down with the police department and said, why don't we follow up when there's an overdose? Why don't we sort of investigate it as if it's a crime scene? To try to get the paraphernalia, try to figure out where the drugs came from. Think of the cell phone. Obviously, someone who's just taken a dose of heroin probably was connecting with his or her dealer beforehand. And we set out, and we did that, and we started what we call the Overdose Response Initiative. It had 2 great benefits. My job is, of course, to go after the supply, first and foremost, to cut that off, and then collectively work with the rest of the community, and certainly in public health, to deal with the demand side as well. So we were getting very good information in terms of going up the chain to investigate who's dealing the drugs, but we were also getting real-time data as to just how bad the problem was. And we started that in February of 2016, and by May we were realizing that in 1 week we had 12 deaths in Staten Island. And so I was able to sort of shine a light on the problem. and got City Hall engaged, which for Staten Island is sort of the forgotten borough of the city of New York, is always a problem, right, Dr. Farley? But we were able to engage City Hall and Albany as well, and really got a focus on how serious the problem was. And so that, I think, was sort of a first step, combining efforts with law enforcement and public health to understand the problem, to investigate who the drug dealers were, and also to help support the families who had a loss. We started doing that with just the deaths, and we would realize in 2016 we had 116 deaths on Staten Island, which is a per 100,000 rate of about 31 per 100,000. We also our office also pushed to put another pillar of our Marshall Plan is harm reduction and make sure everybody has naloxone. So we used our asset forfeiture money to make sure that every police officer had naloxone, the EMTs, and more people who wanted it as well. So with those saves, we started to investigate those as well. So now we're tracking out of my office, the DA's office, real time, the number of deaths, the number of saves. That information is so critical not only for law enforcement, for public health. So that combination has been very effective. Other things that we've instituted, and I know you want to go to the next panelist, have brought us to a pretty positive place, because in 2017 we had about 99 deaths. So we had a 15% reduction in overdose deaths, which for a county our size is pretty unique. So we've been able to bring in all those different forces to bear on the problem. We had a good result, at least year over year, but the overdose rates are still high.
When you first initiated this plan, the Marshall Plan, was there any pushback, or were people excited about it?
Yeah, no, there was pushback, because it took a long time to convince City Hall, we're a 5-borough government, that the problem was severe as it was. We also we started a thing we call the HOPE program. It's post-arrest, pre-arraignment, offer of diversion. But it took me about 12 months of sitting together with the health department, the deputy mayor for Health and Human Services, mayor's office of criminal justice, all who didn't realize how bad the problem was, and sometimes don't like the fact that law enforcement is taking the lead on what they perceive as a public health problem. You really have to address it from two sides, because it is illegal activity as the law prescribes. And so that HOPE program, which I'll maybe talk a little bit more about, that post-arrest pre-arraignment diversion, it took me almost a year to bang heads together so that we could implement that. We started it in January of 2017, and we've had over 400 people diverted away for misdemeanor arrest. They get an offer of diversion at the precinct. They're met by a peer counselor, which is a very effective methodology, and they're going into a course of treatment that is prescribed by the professionals, and then if they follow that, their cases are not docketed, and we dismiss the arrest and the prosecution. So we're trying to use law enforcement in these different ways to address the problem.
Great. Evan, your boss, Dr. Leana Wen from Baltimore, has become known around the country as somebody who is very aggressive in terms of making sure everybody has Narcan or naloxone. She came to Philadelphia to speak at a conference that I hosted, and she, right on stage, did a demonstration, so everybody in the room knew right away how to use it. What has been the thinking behind that, and what impact has that had on drug-related deaths in your city?
Yeah. So first, thanks for having Baltimore City up to participate. Really glad to be here. I'll start in 2015. So in 2015, Dr. Wen, my boss, wrote her first standing order, sort of a blanket prescription for the whole city, so that any of us, any city resident, could get naloxone or Narcan from a pharmacy without an individual prescription from a doctor, as long as they had a little training certificate saying that they had been trained to use the medication. Last year, 2017, we actually got rid of the training requirement, so it's effectively available over the counter. Since then, we've tried to spread the message far and wide, including to our pharmacists themselves, so actually visiting every single pharmacy in the city in person to explain that if someone comes in and asks for Narcan or naloxone, they don't need a prescription. But then we've also tried to distribute the medication directly to our residents who are most likely to actually see an overdose and therefore be in a position to intervene and save someone's life. So that means, for example, people who are currently using drugs, clients of our needle exchange program, but then also residents who live in neighborhoods that are experiencing an unusual number of overdoses. So we get data every day from our fire department, from our EMTs, our paramedics, about every overdose they reverse. And we can see exactly where they're happening and when. And if there's ever a spike, an unusual number of overdoses in one really small area, we'll send an alert, and that's where we send our outreach teams with naloxone to do linkage to care. All told, the residents we've trained to use the medication have told us that they've saved 1,800 lives since 2015.
Wow.
And that's, again, those are just bystanders.
ones you
That
know.
doesn't even include our police officers, our EMS. If you add those in, it's well over 10,000 over the same time period.
Tell me about the cost, because we've heard different things about the cost of Narcan, and how does that impact your city's budget?
Yeah,
And who pays? If I go to get the Narcan, do I pay for it? Do you pay for it?
yeah. So if you go to get Narcan from a pharmacy, typically your insurance will pay, although it varies and the copay varies.
Really? And I don't have to get that off, like, I can just walk in?
It will depend. You should hopefully be able to just walk in.
Okay.
At least that's the case in Maryland and in Baltimore.
It's true in Philadelphia as well.
Okay.
All right.
But of course, the Baltimore City Health Department can't use the Baltimore City Health Department's insurance because we don't have insurance. We're a city agency. And look, I think this is pretty basic. 1,800 lives have been saved at a minimum. Those are just the ones we know about by bystanders since 2015. If we had twice as much money, or if naloxone cost half as much, I think it's very plausible that we would have saved twice as many people.
How much does it cost?
So it depends on the formulation. The list price for probably the most popular formulation at this point, which is Narcan, the simple nasal spray, is $150 for a
Per dose.
2-pack
Okay,
for a kit of 2. And city agencies like ours can purchase Narcan at half off, so $75 a kit. But keep in mind that naloxone is a generic medication. It's available for pennies on the dollar in other countries. We're living in the midst of the worst drug epidemic in American history, and we need to pay $75 for a private citizen, $150 for this medication. And there are other formulations, but they're all too expensive, is the short answer.
Wow. And is there pushback against that to bring down the price?
Not enough.
Yeah.
Pardon me?
I said not enough.
Not
certainly
enough.
cost, the companies produce that, probably pennies, and they're selling it for $37.50 at the best price per dose. It's a generic chemical which you can get for pennies and a little plastic gizmo.
And what's particularly frustrating is that the federal government right now has the statutory authority to purchase naloxone below market price. The government essentially has its sort of eminent domain for patents. They can go to the manufacturers of naloxone and say, this is a life-saving drug. We're in the middle of a drug epidemic. We know that it costs you pennies on the dollar, so we're going to buy this for $10 and not $75, and we're going to distribute this to our states and local jurisdictions. But we're not doing that.
And does it expire, or does it at least stay good for a couple of
It
years?
expires after 2 years.
All right. That's not so bad. Okay. Well, Cynthia, let me turn to you. We have in the intro, and when Dr. Farley was speaking, we heard about medication-assisted treatment, which is something we've been hearing about a lot in terms of this epidemic. MAT for short. What exactly is that, and what has your organization learned about what works and what doesn't?
Yeah, so I'd like to first thank everyone for allowing me to be here today. Philadelphia is my home city, so it's always good to be back home. Medication-assisted treatment, which combines a medication approved by the Food and Drug Administration with counseling, is hands down the most effective treatment that we can offer our patients. We see a lot of good things happen when we provide MAT, or medication-assisted treatment. We see things like an increase in adherence to treatment, meaning that individuals will stay in treatment longer. We also see decreases in overdose risks and overdose deaths associated with individuals who are receiving MAT. We see reductions in infectious disease complications such as HIV and hepatitis C. We see people their quality of life will improve, and they'll be able to re-engage with their community and re-engage in the workplace. So these are all great outcomes, and there is good evidence that shows that medication-assisted treatment can help us achieve all of those things. Now, in 2016 alone, we had, I believe it's roughly 42,000 individuals died from an opioid-related overdose. Now, not all of those individuals necessarily had an opioid use disorder, but arguably a lot of them could have been assisted, and some deaths could have been prevented through the use of MAT. And so it's really important that we increase access to what we know is an effective therapy. We talk about trying to create a treatment system that has several characteristics. We look for access to treatment to be timely. That means that an individual, and we talked about this a little bit earlier, that an individual can have access to care when and where they request it. In general, without regard to the type of insurance they have. We talk about a treatment system that's comprehensive. So there are a number of services that go along with the medications, counseling. So having all of those services that are recommended and supported by the evidence available is also a key characteristic of an effective treatment system. We also look at evidence-based, which is very similar to comprehensive in terms of the evidence shows us what works in terms of the medications and the services that go with it. So we need those services to be covered. And then finally, we talk about a system that is sustainable. And so one of the things, right now, the opioid crisis is taking a number of lives, and it's front and center. But we need to create a treatment system that's going to be responsive to the needs regardless of the substance of misuse. So right now it's opioids, but that's front and center, but cocaine or methamphetamine. And in fact, in certain pockets of a geographic region, opioids may not be the predominant problem. So it's important that your system can respond to that. So there are a number, in terms of creating that ideal treatment system, there are a number of barriers that stand in our way. Chief among them is the stigma that is associated with this disease. We see a lot of individuals that are in fear of seeking treatment. They worry that their families will be disappointed or potentially that they might lose their jobs. We even see a bit of stigma within the healthcare system in terms of people's willingness to use these medications and whether or not they view it, the disease itself as a moral failing and the drugs as a crutch. All of that is not true. We're dealing with a treatable disease. Another barrier to that effective treatment system is not having enough providers. So not having enough prescribers that are engaged in providing these medications, or counselors that can engage with patients to help them manage the triggers and other kind of environmental factors that can lead individuals to relapse in their disease. And so there are a lot of barriers that are out there, but we also know that there are strategies to address them. So there is a path forward. And there's a lot that can be done to help increase access to medication-assisted treatment.
And I don't know if this is a follow-up for you or for you, Dr. Farley, but what about the mechanism of how these medications are administered and how people get them? So, with methadone, people have to come to a clinic. What about some of these other medications? How do people get them, and then how do you continue to take them?
Well, methadone in general, people have to go to a clinic every day, which makes it difficult for people to hold a job and still get that form of treatment. Suboxone is not quite as tightly regulated, and people can get a bottle of pills and over time ultimately have up to 30 days that they can go and just take the pills on their own. But both of these have an awful lot of restrictions that were put in place when they were first legalized for treatment because people had concerns that they were going to become drugs of abuse on their own. And those it may have been appropriate concerns, but the restrictions have made it so that it's very difficult for people to get into treatment, and they create the bureaucratic barriers that we mentioned earlier.
And I gotta just say that when you look at the problem and understand, or to want to figure out why the death rate is so high, why are the overdose rates so high, and it speaks to the urgency of this crisis. So these barriers, whatever the regimen of treatment is, whatever the way out of it is, you're dealing with a landscape where so many people suffer from addiction illness, primarily started with overprescription or over-access of the opioids. But the heroin and the heroin-like substances that are on the street now are much more deadly, much more toxic than they were in the crisis of a generation ago. So the heroin that's on the street is 85% pure, whereby in the 70s and 80s, estimates say it was more like 15 or 20%. And now they've added in fentanyl and things like fentanyl, so which is 150, 200 times stronger than heroin, and it's being marketed as being so strong. And so when you're talking about delays in treatment, you're talking about figuring things, what to do, one more use can be deadly because it's so toxic, and that's what you're dealing with. People of all ages dying at home, dying in their cars, dying in restaurants, as we see it in Staten Island, because it's such a toxic mix. And that's why there has to be more of a sense of urgency in my mind of dealing with the problem, because we can't delay that. Every day there's, as I sit here in other Staten Island, there's overdosing today, and every third day someone's dying. And that's why we have to do more and more quickly.
Yeah. And what are the services that need to go along with medication-assisted treatment? Because it's not like, oh, here's a great medication that will cure all of this. So what else needs to be there? I don't know who.
So I can start that. I mean, obviously, we want to use the medications in conjunction with counseling. The evidence shows us it's best to use them together, but we also need to remove some of the barriers, other barriers that people face in terms of getting treatment. So for instance, transportation to get to those doctor's appointments is often key in terms of the ability to keep someone in treatment. So we do see, particularly at the community level, we see a lot of faith-based groups or other organizations that will try to fill that gap and provide either finances or services to provide services like transportation that perhaps the state or the federal government can't provide because there are restrictions on how they can use that money. But you need to provide, we talked a little bit already about recovery coaches, so individuals who themselves have struggled through a substance use disorder, how these individuals can help individuals navigate through the treatment system and help respond to triggers that might otherwise lead to a relapse.
And even more imminently, we started a program that the city now duplicates, that when someone receives naloxone through government, whether police or fire or EMS, and are taken to a hospital, we dispatch a peer mentor to speak to that person so that, because naloxone, yes, it's saving lives, but you see a lot of people using it 2-3 times a day, so they continue. The fact that they're saved by naloxone is not changing their behavior for the most part, so you need to intervene. And so we have a relay program where we dispatch the mentors to the emergency room to try to talk to them and try to put a warm arm around them and say, come on, there's a different way to go here. And that's showing some signs of success, but there's a lot of recurrence with the naloxone users, with the Narcan users.
Let me turn to you, Dr. Farley. Give us a brief overview of, this problem in Philadelphia. We often frame it in terms of the overdose deaths. That's sort of the number that's on everybody's mind, but there are other circles that form around this program. So tell me a little bit about this problem. So tell me about who is affected and what's the dimensions. What are the dimensions?
Yeah, so I often think of this problem as the way we see it is kind of like the 5 blind men and the elephant. It has many different manifestations to it, and people see one manifestation and think that's the problem, and that's only a piece of a much larger problem. So that the larger problem includes not just fatal overdoses and not just non-fatal overdoses, but includes people who are using these drugs and, say, not able to function at the workplace well because they're under the influence. It includes the babies born addicted and neonatal abstinence syndrome, which is really rising very quickly. It includes a transmission of hepatitis C, which is a problem that we were getting a hold of, but now it's getting much worse. we have a diagram that I sometimes show about the tip of the iceberg. So if the tip of the iceberg in Philadelphia is 1,200 overdose deaths, we can estimate that how many people are injecting heroin in the city, and it's probably in the order of 70,000. We did a survey last year that how many people are currently taking prescription painkillers, and 1 in 7 are regular users. That's 168,000 people. And then in that survey, how many people got a prescription in the last 12 months for prescription painkillers, and that's 1 in 3, so about 460,000 people. This is an entire city that's floating on opioids, and we're only seeing these different manifestations about the worst aspects of it. Actually, one other aspect I didn't mention was homelessness-related opioids. Homelessness in the city is rising, and that's what's driving these opioids. So we have to, while we try to deal with primary prevention of the problem and get fewer people addicted in the first place, we still have to manage all the downstream problems at the same time.
Now, let me ask you about prescribed opioids, because is that where you put sort of the origin of this problem, and some of your prevention focus is on that? But, I mean, many of us have been prescribed opioids at one point or another and have not, developed an issue related to that. So there are other factors that are driving this problem. So how do we tease that apart and then focus on the right things? And that's something anybody could weigh in on.
Yeah, there's a graph that the CDC people showed a few years ago about showed an increasing line in the number of prescriptions for opioids, an increasing line for the number of people requesting treatment for addiction, an increasing line for a number of people having fatal overdose deaths, all going in perfect parallel. And so, yes, while most people who get a prescription for painkillers don't become addicted, you know that the more prescriptions that are out there, the more that people are going to become addicted and have all the problems associated with that. And so we need to reduce prescribing. If you look at the graph on prescribing, we know that it's fallen 10%, 20% in the last couple of years, but we're still way above what we were in the 1990s. Doctors are still prescribing much more than they ought to. I estimate we need to reduce prescribing by about 75% if we're really going to get this problem behind us. Even if we could do that today, we still have to deal with all those tens of thousands of people who are currently using or dependent on the drugs.
And to add to that, so then the graph that the doctor cites and that information is 100% correct. And also anecdotally, we still see when we respond to overdoses, we still see sort of a collection or a mixture of heroin and the opioid painkillers and the benzos are all mixed together. And you see that in many times when we respond. Or if we make arrests of drug dealers, you'll see that in their cache they have heroin, but they're also mixing that and pushing the pills as well. So it's very, very active, and that nexus is very, very strong. And I guess I think that there, some people can take a few painkillers and you don't get addicted. Other people, I think, have a more tendency to have a more addictive personality. We see that. But it's also, somehow it got into the mindset of people to use it as recreational drugs. So we have stories of kids going to parties and getting pills out of the parents' medicine cabinets and throwing them all into a fishbowl and then just sort of grabbing a couple and taking them as sort of a recreational activity. And you do that long enough, and then you're addicted. And then, as say in New York State, we really pushed efforts to limit the prescriptions, and so you can't give more than a 7-day amount, and the pharmacies are even limiting that. But then people who suffer from the addiction, they slide over to the heroin because it's much more cheap, and incredibly accessible, much more so than it was a generation ago.
Yeah.
An important part of the overprescribing picture to talk about is, the effectiveness of opioids for long-term chronic pain. It's not good. There's not strong evidence. And in fact, we could be doing much better in many cases for our patients in terms of how we help them manage their pain. There are other medications. Sometimes we'll use opioids for nerve pain or for migraines, but there are therapeutic alternatives that can actually get patients better relief. There is physical therapy. There are other types of alternatives. Now, there are insurance barriers and other things we could dig into, but I think key among that is we tend to move towards an opioid prescription as the solution when in fact there are likely better solutions that we can offer in terms of chronic long-term pain.
And Evan and others, what are some other drivers of this problem? Because we talk about these prescription pills, but there are other things that drive people toward perhaps a feeling of hopelessness, or, I mean, there have to be other things. So what do you think about those things? What are some factors that you think, Evan, in your city have contributed to this issue, and you as well?
Yeah. So people make a lot of causal claims about this. And I think a lot of those causal claims are actually pretty hard to make. But it does seem unambiguously true that overprescribing has been a major driver of this problem. And even though it doesn't seem obvious that hopelessness or despair is alone a sufficient cause for opioid addiction, I think anyone doing this work will say that it is a really important factor in a lot of the lives of people who become dependent on or addicted to opioids. And this is, of course, true in the city of Baltimore.
Yeah.
Where entrenched poverty is widespread and long-standing. And I think this is difficult because we face a public health crisis, but a public health response is not going to give people who do not have a place to stay a place to stay. And it's not going to give people who don't have jobs, jobs. And I can't exactly speak on behalf of the health department, my employer, in saying this, but it does seem like we found ourselves in a place where for a long time the basic needs of our citizens have been unjustly unmet, and we are seeing one symptom of that injustice. And there are effective ways to treat that symptom, some of which we've already mentioned, more of which we'll talk about. But we will have only treated a symptom.
But it's just to show you how complicated this problem is. Staten Island is a solidly middle-class community where poverty is not sort of the driving factor behind this crisis. I think it's more the overprescription, and it's actually access to health care. Health insurance, a lot of municipal workers and their families, and so it's not, poverty is not the main factor there. It's certainly the access. I think there's a little bit of that, maybe, I don't know, the lack of boredom or depression. Staten Island, like many communities across the country, has suffered some sort of collective traumas through 9/11. We were the hardest hit by far in terms of personnel. A third of the firemen came from Staten Island who were killed in 9/11, and then Hurricane Sandy devastated a large swath of the eastern part, and that's where we see actually the largest concentration of the problem. So it's, yes, it's in some communities it's driven by poverty and lack of opportunity. In others, it may be just the opposite, and that's how pervasive this problem is. There's no simple cause, and thus there's no simple solution.
How have you seen the sort of ripple effect of this issue where you live and work?
Sure. So it's devastating families. It's ripping them apart. It's the main topic in many of the neighborhoods that people talk about. Lives are not only being lost, opportunities are being lost, and it's really having a devastating effect, I think, on a generation in particular, but throughout the community. And so you see it sort of taking hold on the whole community and being the number one problem from both law enforcement and from public health.
Mm-hmm. And where do you see the biggest barriers of getting people into treatment? Talk about what access people have where you are and what's keeping them from going in.
So as I mentioned before, we try, anyone who comes in contact with the law enforcement system, with the criminal justice, we try to immediately get them right from the precinct into treatment. And we think that that's the best way to go from my perspective. I think the other barriers that were spoken about here, access to treatment, the ability to pay for it. There's not treatment on demand, and obviously with a problem like this, if someone is suffering from addiction illness and they want treatment, they should be able to get it on demand. There's no question about it, because in the long term it will save their life, because one more day, one more usage, it could be the last, right? And so we have to have access demand across the board, and whether it's medically assisted treatment, counseling, inpatient, outpatient, whatever it is, it has to be tailored for the individual. That's what we do with our HOPE program. and that has to be available on demand.
And who pays for that? Because that's also very expensive.
Yeah,
so-
it is, but it's, we could have a longer talk about health insurance and one single payer or not, or a government option within Obamacare, but that's a greater discussion. But the problem is, you see it with this crisis, that lack of access is not only making people chronically sick, so acutely sick that they're dying right in front of us.
And we haven't talked about relapses yet, which happen and happen frequently. So how does the system handle that, handle the cost of it, and make sure that even though there is a relapse, the person gets back into treatment?
I'll just say that substance use treatment is effective. People get in recovery. But we do recognize that that's a part of the pattern of the disease is people have relapses. That typically it's years or decades from the time that people first start using substances to the time they really have long-term recovery. So we have to build that into our expectation that people are going to have problems and we need to get them back into treatment at that time. Even if they're on treatment for a period of time before their relapse, that's a period of time when they're not dying from drug overdose, so that there's a value to this even during that time when they're struggling and going in and out.
But also, too, I think it's important to, we talk about it as a chronic disease, and it's expected that people will have relapses, and, to think about it in the way we do with other diseases. So if someone has diabetes and they lose control of their blood glucose, we don't deny them treatment or say, sorry, you had 6 months of treatment, that's all you're going to get. We're not going to treat your diabetes anymore. So it's really important that we think about it that way. And then we've talked about costs with a couple of questions. But one of the things we haven't talked about yet is cost avoidance, right? So providing naloxone and providing treatment does require funding to do. But when you look at the cost of prescription opioids alone, it's estimated it's costing the country about $78 billion a year in lost productivity and criminal justice cost and health-related costs related to emergency rooms and hospitalizations. And so with effective treatment, we can avoid some of those costs as well. And that's important to always keep that in mind as well.
Evan, where do you see the biggest barriers to getting people into treatment in Baltimore?
So I want to talk about 3,
Okay.
if I can.
Sure.
I think the first is that often we are operating with a false conception of what treatment should look like. And so one barrier to accessing treatment comes down to what we mean by the word treatment. So if a loved one, if your brother, your niece is dependent on or addicted to opioids and you want to get help for them, I think a lot of people just go to Google and they type in drug rehab. And how the heck are you supposed to navigate that? You have no idea what works, what's real, what's a sham. I mean, you can end up sending someone to a abstinence-only rehab facility in Florida that costs $50,000 a month.
Yep.
It's not
And
gonna-
people do that.
Yeah.
People do that. And it's in part because of the way we talk about addiction, a way that's different than the way we talk about just about any other disease. So I think that's one sort of initial barrier. We're not even looking in the right place. But then the second related barrier is even if the information has been successfully communicated that medication-assisted treatment really is the kind of treatment that works, it's still not obvious where you actually turn to access that kind of treatment. Again, because we've largely segmented mental health and addiction treatment so that it's separate from the traditional healthcare system. So, your first call is not to your doctor, but it really could be and probably should be. So in Baltimore, we've worked, like in Philadelphia, to expand addiction treatment into the primary care setting and into our hospitals. But we've also created a 24/7 hotline that anyone can call if they're in crisis or if they're not in crisis, but they just need to know where to go. They need a referral to a treatment provider. That hotline gets 1,000 calls a week. So the demand is there. As Dr. Parley was saying, it's just that it can sometimes be difficult to channel it and to connect people with treatment. And I guess the last thing I'll say is that, I think this can be really overwhelming because we're talking about all of these amazing ideas, some of which have been implemented, and we're seeing pretty good preliminary results, and yet the numbers keep going up. And I think it's reasonable to ask why, and to think that we're missing something. I think part of the story is that we continue to fail to leverage all of the opportunities for intervention that we have.
Yeah.
So we've done a lot of that, say, in these criminal justice diversion programs, but it still remains the case that in most primary care offices in America, in most emergency departments, in most hospitals, and in the vast majority of jails and prisons, you cannot get treated for addiction. Which means that anytime any of our residents move through those systems, even if we find out they're addicted to opioids, we cannot act on that knowledge any more than just giving them a name and a number on a piece of paper and hoping that they call.
Because those doctors would not prescribe those medications or cannot, or
Right,
what's the breakdown? Or
Yeah, so Dr. Farley was gesturing toward some of these barriers earlier. So one is regulatory. I mean, the federal government really tightly controls some of the medications that are used to treat opioid addiction. So it's a
and
hurdle.
that probably makes sense because, I mean, we could get ourselves into another problem, right, if we overprescribe those. I mean, just putting that out there.
I think it makes sense in the sense that it is understandable why people were concerned. I do not think it makes sense in the sense that I think the regulation should remain in place. They should not. So the federal government could, for example, eliminate this special training requirement that doctors need to complete before they can use Suboxone, one of the medications. They could reschedule methadone. You don't have to dispense methadone in this special facility, a methadone clinic. In Canada, you just get it from a pharmacy, like any other medication. And they're doing fine. So I think those regulatory barriers, they were probably grounded in good intentions, but we don't need them anymore. And they're a big reason that this treatment is not available, particularly in primary care offices, hospitals.
But I think there's another barrier to people getting treatment that has to be discussed, and I see it every day as we make offers to people to pursue a path of treatment tailored for them, and they refuse to do it. And that is the individual's choices and decisions that they're making because they suffer from addiction illness. There are a lot of people who have that illness, and even when treatment is available, they're not choosing to take that path. And that's something we have to address as well. The person who's in diabetic shock will walk into the doctor's office and say, help me. Not everyone who suffers from this illness understands that help is there. And I think that really goes to sort of a public awareness campaign and a more thorough education in the schools so that people understand how serious this problem is, what they're involved in, and how they have to follow a path out of it. And, if you think about it, 30 years ago, I'd be sitting here smoking a cigarette. I thought half the people in the room would be smoking cigarettes. And now if I lit a cigarette, Dr. Farley would come in. And
The sprinklers would start.
This is an inside New York City joke, and as I drink my 64-ounce sugary soda. But because we as a society know that how bad smoking is and how, and I don't think we're having that discussion enough so that people have it ingrained in them that when they're following this path that they realize, I have to get out somehow. And many do, and don't get me wrong, and we try to work with them, but there are a lot of people every day that we're offering a different choice to, and they're saying, no, I'll take my 15 days in jail because I don't want to.
Right.
And so we have to be honest about that as well. As much as we make treatment options more available, whatever right for that person, we have to find a ways as a society to convince them to take that path.
I want to ask about medication-assisted treatment because there is still sort of this narrative that if you want to quit drugs, you have to get clean, and I'm making the air quotes, and if you use or if you take another substance to help you in your recovery, then that's not the real thing. And even in the NA and AA and so on, those communities, there is still that narrative. So are people worried about, well, if I'm doing that, that's a crutch and I'm not really better. I'm just trading one problem for another. Is there that consideration too?
And there's still a lot of self-stigma. I mean, there's a lot of societal level stigma going on, but self-stigma where individuals are afraid to seek treatment or they're afraid to use the medications. As part of the work that we've been doing with states to help them improve their treatment systems, we've been doing focus groups with patients. and their families. Because one of the things we want to know is, as policymakers, you think you know what works, you look at the evidence, but it's really important to look at, from the eyes of the individuals who are trying to access the treatment system, what that looks like, what barriers are they facing, what does it really feel like. And we're still in the process of analyzing those results, so I can't necessarily share specifics of that right now. But one of the things we're learning is there is a lot of self-stigma, and people do look at the medications as a crutch. And again, it goes back to this lack of understanding that we're dealing with a chronic disease here and that there are medications. And people self-stigmatize, practitioners stigmatize, society stigmatizes, and there are things we can do to help address that, even with terminology. We hear people talk about dirty urine tests or users or addicts. These are all stigmatizing terms that introduce shame into the discussion, and we can go a long way in terms of helping people feel more comfortable with having that discussion, and providers being more comfortable, even if we start by getting rid of some of that terminology that introduces shame.
I think that goes back to the education and also sort of a grassroots movement. In Staten Island, we love our lawn signs. And so we started a lawn sign campaign, Staten Islanders Against Drug Abuse, with a very broad listing of a website they can go to get any help that you need. Yeah. But it's a way for everybody in the community to say, listen, I understand this is a problem. Let's remove the stigma. There's help for you. And we've put about 5,000 out. They're all across the island now. It's just one way of trying to reduce that stigma and get people to understand that it's a problem facing everyone. There's help for you. Come and come forward, and we'll try to help you. But it's got to be a part of everyday dialogue. It's got to be something talked about in the schools more, it has to be done that way.
There's a very practical aspect of this that is really feeding into the fatal overdose crisis, and that is people wanting treatment end up going into detox, and they'll spend some limited number of days where they go through detox, then their tolerance for opioids goes down, they come out, they relapse, which is what happens. They use the same amount they were using before, but now they're not prepared for it, and they die. And so it's often people, when they feel like they finally solved the problem, they're out of rehab, and they're kicked the habit, that's a prelude to them dying. And so we do need to think that the idea of detox, we're trying to get away from detox as a concept here in Philadelphia, and really talk about medication or withdrawal management to deal with the withdrawal symptoms rather than have them suddenly become clean with the risk that entails.
I find myself getting sort of polemical about this issue because the numbers are just getting so bad that it's hard sometimes to summon the time for politeness. But I think that folks who object to medication-assisted treatment, they need to be able to say two things. So one, they need to be able to say to someone who was dependent on or addicted to opioids and whose life was saved by, say, buprenorphine, who was able to get a job, to reconnect with her family, her children, her friends, to say to that person that none of that counts because she takes a little film every day. I don't think that's a reasonable thing to say. I don't think the second thing is a reasonable thing to say either, and that is an explanation of why only in the case of opioid addiction do we think that physiological dependence on some substance that's not produced by your body doesn't count as treatment. If someone, to return to your example, has diabetes and they rely on insulin, they're physiologically dependent on insulin, we don't view that as a problem. If someone is taking buprenorphine, Suboxone, or methadone every day, they might be physiologically dependent on those medications in the sense that if they didn't take their medication, things would go south. Well, we're perfectly comfortable with the idea that if you don't take your medication, things would go south. They're no longer addicted. That's not how we define addiction. Addiction is not constituted by or exhausted by just relying on a thing. It means that you rely on a thing so much that you continue to use despite adverse consequences to yourself, your relationships, your life.
Yeah. I want to talk about something that's been controversial and stirred up a lot of emotions, which is safe injection sites. you know, if we think about harm reduction and how controversial that was, even needle exchanges were very controversial a while back. That's not so controversial now, but safe injection site is controversial. So, Dr. Farley, what is a safe injection site, and do we want one in Philly?
Yeah, so we announced a few months ago that we believe that Philadelphia could benefit from what we're calling comprehensive user engagement site.
Hold on, what is it called? What's the official?
Comprehensive user engagement site, or as we
right.
call them, CUES, to emphasize that these are sites where people who are dependent on opioids but are not in treatment, despite all of our efforts to get them into treatment, can go in, engage with professionals that can help them, counsel them, help them with a variety of services. But during the time that they are continuing to use, they can use at that site under medical supervision. So if they have an overdose, it doesn't become a fatality. They can stay alive until they're ready to go into treatment. There are none of these facilities in the United States right now, but there are over 100 across the world. Strong evidence base that they save lives. We visited the site in Vancouver that's been in place for 15 years. During that time, they've had thousands of overdoses that have occurred on the facility, not one fatality during that time on the facility. And a good study showed that they reduced overdoses in that immediate neighborhood by about 30%.
And did they get people into treatment too?
And they get people into treatment as well. So one cohort that followed that had about 1,000 people who had been using on average 17 years. Over 2 years, about 50% of them got into treatment. Now, whether they got into treatment permanently, I don't know, but they absolutely serve as an entryway into treatment. And so it's a way of engaging people and keeping them alive until they're ready for treatment. It's part of harm reduction, that approach. And yes, they are controversial, just like syringe exchange programs were controversial. But syringe exchange programs, in retrospect, have proven to be probably the most effective thing we've done in fighting the AIDS epidemic. The number of new infections in injection drug users from HIV in Philadelphia has dropped by 90% since we opened up syringe exchange programs. So this is absolutely one really important piece of the many things we need to do to address this huge crisis.
I guess where you put it will be a big issue, right?
Yeah, but let me just point out, the studies in Vancouver show that it reduces a lot of the community problems that people perceive, because people are no longer injecting on the street, right? They're injecting inside so that your children don't see them injecting on the street. There's no longer needles, or many fewer needles that are on the ground, because people are using it at a site where the needles are thrown away in the trash. And so, yeah, people are certainly uncomfortable with this idea. It's a new idea, but it actually is an improvement to the neighborhood as well.
What about you, Evan? Are you considering this?
Yeah, so Dr. Farley spoke about, the evidence base for this intervention and the effect on surrounding neighborhoods. I think it's also important to, think through what are some of the reasons for which people are uncomfortable with this idea. And it seems like two come up pretty often. So one is that these sites, these spaces will somehow normalize heroin use. It'll send the message that it's okay and normal to use heroin. I think if we think about that for even like 4 seconds, we're not at risk as a country of giving the impression that injecting heroin is just like a totally kosher thing for people to do. I think sometimes there's the implication that it is a normalized practice. I don't think that stands up to scrutiny. But then the second idea is that, well, for individual people, say who are right now currently addicted to heroin, they're using drugs, it will make them use drugs more frequently because, say, it will lower the costs. And this is often the argument that people offer in response to different harm reduction interventions. Well, you're making it easier for people to use drugs. But I think the really important thing to remember is that by definition, drug use when you are addicted to drugs is drug use that persists despite negative consequences. People who are addicted to opioids don't use heroin only when it's easy for them to use heroin. In many cases, it has already cost them most, if not all, of the relationships in their lives. And so I think the incentive argument that people offer in response to a lot of these harm reduction interventions really doesn't stand up. We saw that it didn't stand up with needle exchange programs. And once you sort of dispose of those two objections, all you're left with is a really large body of evidence from across the world suggesting that this could save a lot of lives.
Okay, but let me turn to the DA. Because we are you are creating a space where people are engaging in an illegal activity
Mm-hmm.
right in front of your very eyes, and you're paying for that facility. So that poses some questions, right? And from where you stand,
It does. It poses some very serious
and it
questions
blurs the
in that
lines a
regard.
bit.
And there, you know, the one thing I want to, well, let me say this as a chief law enforcement officer of the county that I serve. I see my job as enforcing the laws as they exist. And so, and that's my job. I have to do it. I don't turn away and not enforce the law because my own personal beliefs, the laws are on the books, and my job is to enforce them fairly and justly based on what the facts show me. But what I think people have to understand, too, is that this crisis is a little different, I think, than crises in the past. At least what we're seeing in our town is that people are injecting and using not so much out in public anymore, not so much under the train stations and in neighborhoods that are maybe a little bit more distressed. This has become very mainstream. People are using in their houses. Family members are administering naloxone. People are using and actually in the sanctity of the home. We see that very much. In fact, last year, a majority of cases that we responded to were in homes. And so the notion that we have to move the usage off the street into a safe place, I don't know if that is as appropriate in this instance as it was in the past. But what I will say, and I might sound like a politician here, is I also I don't get involved in what is the best course of treatment for the individuals that we try to deliver up and direct to the provider community, whether it's abstinence counseling based, whether it's medically assisted treatment, whether it's some sort of other managed. We don't get involved in that. We just want to know that someone is following a path that's best prescribed for them.
Any follow-up on safe injection sites?
Just that, you know, this opioid crisis has different, plays out in different ways in different locations.
Yeah.
There definitely are plenty of people who are using at home and taking pills at home, and in fact, the majority of overdose deaths in Philadelphia are occurring inside a residence. But our image in Philadelphia is those people in Kensington who are injecting on the street and dying on the street. And there certainly are, in Philadelphia, there are plenty of people like that. The folks in Kensington are having a tough time seeing drug users all the time. And as their kids walk to school, they see them putting needles in their arms. And I'm very sympathetic to that. So for that population, a facility like this would really work. It may not have that same need in every location in the country.
So let me see what time it is. All right, we're about to open things up to all of you, so start thinking about your questions. I want to do two more sort of pieces of business. Any thoughts on prevention? We have touched on it, we have talked about it, but what would be your main focus points for prevention? You mentioned talking to doctors. What else?
Well, let me just say, we haven't yet mentioned the pharmaceutical companies here, but doctors didn't just spontaneously start overprescribing. They overprescribed because the pharmaceutical companies pushed them and induced them to do that. And so we are suing the pharmaceutical companies. That's part of the solution as well.
And you are as well, right? Or other people?
Yeah, in New York City we are as well, yep.
And so, I mean, I think reducing overprescribing is a key part of all this. I do want to mention there is also a contribution of the illegal drug markets that's happening simultaneously but independent of that. So the district attorney told us earlier, the drug cartels have managed to deliver a purer and cheaper form of heroin to the streets of Philadelphia than they ever have before. You know, for $5, you can get really good pure heroin on the streets of Philadelphia. That's a problem in its own right. And then fentanyl is on top of that. And I think of fentanyl as just throwing gasoline on a fire that's already raging. Fentanyl is the genie that's out of the bottle. It's more potent, more addictive, more deadly than any other form of opioid. We're going to all have to figure out how to deal with that. And I do think that there is a law enforcement role here to try to, as much as we can, disrupt the illegal drug markets. We know we're not going to be able to get rid of them, but if we can try to reduce the number of drug dealers on the street, try to reduce the amount that kids are being offered these drugs, we can at least limit the kind of exposures that can have bad consequences over long term.
What are your thoughts on prevention, sort of focus points for your city?
Yeah, I mean, Dr. Pirelli really took the words out of my mouth. I think as a general point, it's really important that we focus on prevention programs that are evidence-based. You know, for which we actually have reason to believe that they work. I think there's a real risk in all of the work that we do, but particularly when it comes to prevention initiatives, to just do what feels good and what feels right. And that often leads to programs that are not so far from basically going into schools and saying, by the way, probably don't do heroin, which, no surprise, does not lead to fewer people doing heroin. So I think in both the way we message our public education campaigns and in the specific ways in which we intervene with doctors, with hospitals, that we're actually attuned to the effect that we're having on the prescribing rate, on people's attitudes, and the like.
Okay.
When it comes to prevention, one of the evidence-based tools that we have available is the Prescription Drug Monitoring Program. Those are the state-based databases that house the information on the dispensing of controlled substances. And here in Pennsylvania, they just recently relaunched their PDMP, enhanced it, provided access to providers, which in the past hadn't been an option. But one of the other steps they also took is they are requiring prescribers and pharmacists to check the database under certain circumstances. A lot of states are doing that now. And it's one of the things, obviously sometimes providers see it as a burden because it's a busy environment where they're trying to care for patients. But really we should be looking at it as an opportunity, right? You can use the information in that database to identify individuals who are at risk, to make better prescribing and dispensing decisions. The Surgeon General just recommended that more people carry naloxone. One of the groups that they've suggested carrying naloxone are those receiving high doses of opioids. So you can use that information in the database to identify those individuals and their family members. One of the things that we are doing at Pew is we're doing research on, how can we improve PDMPs? How do we remove the barriers? How do we make it easier for prescribers to use that information? So we're looking at, what information best informs a prescribing decision. How do you display that information so that people can access it more quickly and comprehend it? And have that patient engagement and a dialogue. We can really use it as a tool to start a dialogue with a patient about whether or not their pain is being managed effectively, whether or not there might be a need for treatment. So it's a prevention strategy that ultimately has the potential to aid in treatment as well.
Mm-hmm. How about you?
To me, the only way to have effective prevention is for everyone to realize that this problem is a multi-headed hydra. There is no silver bullet. There's no silver solution. So MAT is not going to solve the problem alone. There is evidence-based education programs, but they're not being effectively brought into the schools. We are not speaking to this problem as honestly and directly as we should. Where the public, the government says, yes, this is a terrible crisis. More people die from this than car accidents and gunshot wounds combined. But where the ad campaigns, the public service campaigns to talk about this problem, like we have others. And so I hope no one leaves here today thinking, oh, there's just one thing that we have to do that can solve this problem. It is not. And the long-term solution is preventing people to get into the point where they are suffering from addiction illness long-term. And everything we've talked about is part of that. But this discussion has to be happening at the dinner table, in the schools, in the community centers, at the precinct councils, everywhere across this country. And until we do that, we're just, it's going to overwhelm us. We're not going to succeed.
Last question for all of you. If you could do anything, so you're king of the world and can do whatever you want to get a better handle on this issue, what would you do? What strategies would you put in place?
I think the district attorney made a really important point, which I just want to emphasize. There is no one solution to this problem. Because I have run into that a lot when people say, well, don't open a comprehensive user engagement site. Instead, you should do prevention and treatment. I say, well, we are doing prevention. We are doing treatment. But we also need a comprehensive user engagement site. We also need to get doctors prescribe us. So this is too big a crisis to say we will have one solution. We need to have many different pieces to this. And let's be honest, it's going to take us years to work our way out of this. Even if we do it all right now, just given the magnitude of how many opioids are out there.
Okay, so what would you do? So give us some, if you had,
I would put policies in place to get doctors to prescribe less. I
Okay.
would reduce the bureaucratic barriers for medication-assisted treatment with the goal of treatment on demand. I would get naloxone in everybody's pocket in the city of Philadelphia.
Okay.
And make it so that anybody who comes in contact with the criminal justice system who is using opioids can get directed right into treatment. And I would say that anybody who has a non-fatal overdose and shows up in an emergency department gets walked into treatment.
all right, good start. What about you?
Yeah, I'll say two things, understanding that there are many more. So first, just to really emphasize this point, medication-assisted treatment, jails and prisons. Rhode Island just did this, first state in the country to make MAT available to all people incarcerated in all their jails and prisons. The mortality rate among people released from jail or prison in Rhode Island went down 60%. 60%. The total number of overdose deaths in the state, it looks like went down about 12% last year. Second, I think we need a Ryan White program for the opioid epidemic. Some of you may be familiar with the Ryan White program for HIV/AIDS. Near the height of the HIV/AIDS epidemic in the 90s, as a country, we said we are going to commit to providing clinical treatment, even for people who are uninsured or underinsured, and we're going to provide long-term funding to states and local jurisdictions to pay for the other services that, when wrapped around clinical treatment, make it much more effective, but that are probably never going to be paid for by insurance. If we had a program like that, and actually my congressman, Congressman Cummings, Elijah Cummings, and Senator Elizabeth Warren just introduced a bill 2 days ago proposing just that program, which I'm proud to say was my boss's idea, as they've said publicly, then it would be so much dramatically easier for a jurisdiction like Baltimore to actually guarantee treatment on demand instead of putting this together through a patchwork of one-off, 1 year, 2 year grants.
And just chasing that money takes so much energy. Got
Right.
it. How about you?
Yeah, well, I would echo what the other panelists
Yep.
have said. It's multifaceted, right?
Yes.
We need prevention, we need treatment, we need recovery services and policies and programs. And, you know, we shouldn't take our foot off the gas pedal on any of those. We need to keep up all those efforts. If I had to, you know, focus in on one area, I would hone in on treatment because I think there's a great opportunity there. There are 115 individuals dying every day from an opioid overdose, and we could save those lives. And so failing to get people into treatment as quickly as we can is something that we can take steps to address. So, you know, one of the things they talk about is that every door should lead to treatment. So whether you're talking to a specialist or your primary care provider or your pharmacist, or if you're in the hospital for surgery, a lot of times this is when we discover that someone has a substance use disorder because they're not in control of their own lives post-surgery, and so they experience withdrawal systems. That's an opportunity to engage individuals and get them into treatment. So every door should either directly or through referral lead someone to treatment. And to me, that should be a focus because there are lives that we can save every day if we do that.
And you?
Well, just on sort of a wish list type of answer, I need more detectives to disrupt the supply that's coming in. It's too accessible. There's too much of it on the streets now. And for me, it's education to long term. There should be a mandatory curriculum in the schools. You know, comparing it, and the Ryan White legislation is a positive step, but in the 90s in New York City, the death rate from HIV/AIDS was about 4 per 100,000, as the numbers show. Remember what I said in Staten Island, the death rate per 100,000 is 30 from this crisis, and yet we don't have mandatory education in the schools. We don't have public service announcements, not only trying to reach the people who suffer from the addiction illness to try to get out, but also educating family members as to what to do if you have that circumstance, how to reach out, how to get help, how to prevent it. For some reason, not only are the opioids and heroin too accessible, but it's become acceptable to use them, and people it should be ingrained in them more. And I don't want to make light of it, but think of my cigarettes analogy. Again, 30 years ago, we'd all be smoking, and yet through a long-term public service announcements and public health and law enforcement coming together, we've changed behavior. And if we don't change that behavior, ultimately, we won't be successful. It will continue. So, yes, those who suffer from illness, they need the help. I steer as many people as I can into whatever's best for them. But if we don't take this on with a long-term view of changing how people think about these drugs and changing what happened, that confluence of the medical community and the pharmaceutical company and what they did in bringing this crisis to us, we'll never get out of it.
All right, let's hear from you. Questions? Oh, lots of questions. All right, where are our microphone people? They'll just start coming around. So take your... And if you can, because there's a lot of questions, I'm going to encourage people to keep their questions fairly short. Not working? We can hear you, so I can reiterate what you asked while we figure this out.
Thank you so much for the panel. I've learned a lot this morning. I'd love to hear you talk about the racial component of the opioid crisis.
Yep.
In comparison to other addictions and diseases that our city and our nation is battling, and the attention that's placed here, and whether or not we should be doing a similar effort for other crises.
All right, I don't know if everybody could hear. The question was about the racial component of this issue and how this crisis has been addressed and sort of who is affected and how we have dealt with similar crises and so on.
Yeah, so let me handle that. At least in Philadelphia, this is perceived as being a problem of white people. And it is disproportionately affecting Caucasians. On the other hand, every demographic is absolutely affected by this problem. So if we look at fatal overdoses in the city, 25% of those are among African Americans, 10% of those are among Latinos. The number of people dying of overdose, African American and Latino, is more than the number of people dying of homicide. This is a city where African American young men are really killed at tragic rates from homicide. Still, there are more of them dying of overdose. So this is affecting every demographic. It is raising the issue, though, that I think is an important issue, and that is our societal response to the crack epidemic. And there's a lot of appropriate bitterness that our societal response to the crack epidemic was lock them up, they're criminals, and an awful lot of people suffered an awful lot with a second problem of incarceration after they had their crack addiction. And so I feel, and the mayor has said quite honestly, that that was a mistake. This was something that society did because these people were African American predominantly, made it too easy for people to be punished for their problem. We should not repeat that mistake for this drug crisis or for any future drug crisis. We need to see this as a treatment problem rather than a criminal justice problem. And we need to acknowledge the appropriateness of the bitterness in our response to that previous wave.
But I would like to ask, the crack epidemic was also several decades ago now, and there have been significant advances in understanding addiction, as a disease, if we think about the decade of the brain that happened in the 90s, brain imaging. So we have also learned a lot in the years that have passed, correct? So we have more tools today than we ever had before.
We've learned a lot in opioids. We do have the advantage of medication-assisted treatment, and there isn't
Which we
any
didn't,
equivalent of methadone for cocaine addiction. I don't think that's the difference in the reason of our societal response. I do think that it was fundamentally because of race and racism that we responded as inappropriately as we did to the crack epidemic.
Mm-hmm.
I just wanted to say, I think it's important both to acknowledge the racism that it partially explains the country's different response to the opioid epidemic, to leverage the resources and attention that's being paid now to help people in need. But it's also, to your question, I think really important to think not just about how we're now responding to this drug epidemic and how we will respond to future drug epidemics, but how we are also responding to other problems whose victims are disproportionately Black Americans. So thinking of homicide in Baltimore. I think that's a really good point.
Next question?
Yeah, my name is Glenn Wilson, and I am a recovering addict. Is anybody up there recovering? I don't want to break your anonymity. My question, to follow up that question, is this. The demographic, even with those statistics, Dr. Farley, 65% of the overdoses are white. Where you put the euphemistically called comprehensive user engagement site to service predominantly white people shooting drugs is going to be in a Black or brown neighborhood. Where there is demand, there will be supply. What happens to those who supply the drugs, the Black and brown boys that supply the white kids going to shoot the drugs? Understanding that one of the devastating effects of the crack epidemic is you have over 300,000 ex-offenders now, largely with possession with intent felony convictions that will haunt them for the rest of their lives.
So we haven't said where a facility like this would be most appropriate in Philadelphia. We have only said that it should be close to where we have the highest density of drug users so that they can make it convenient for them to use it.
Which is not in Chestnut Hill.
It's where the drug users are because people aren't going to travel that far to use a site like this if they're injecting several times a day. I think it's important to get drug dealers off the street. That doesn't mean that we should lock them up forever. It does mean that we should get them off the street because they're contributing to the problem. I think I may have taken from your question, too, an uncomfortableness with the idea of the comprehensive user engagement site. And again, I'm sure a lot of people are appropriately uncomfortable with the idea, but I think of it this way. If it was your daughter who was addicted to heroin and shooting up several times a day, and you tried everything you could to get her into treatment, which is what as a parent you would do, and she was still injecting, which is what happens to addiction, you'd say, well, I kind of would like to keep her alive until she's ready for treatment. And every drug user is somebody's child. So I think we owe that opportunity for all drug users.
But let me ask you, you raised a good question about the law enforcement end of things. Right. And I guess, so is there going to be a perimeter around there where the police is not going to go? I mean, how...
Well, in general, the police are not going after drug users in Philadelphia right now. There's so many, I see no point in arresting drug users. They are trying to go after drug dealers. So people who are simply using this site as users would not have an interaction with police any more than they are right now. So it really doesn't change what the police department needs to do.
And I just want to be clear, too, at least from our perspective, from law enforcement, people who deal heroin today are prosecuted, and we try to convict them for doing that. We are going after people who are dealers. There's no question about it. And to Dr. Farley's point, so we've been analyzing the overdoses and the arrests in Staten Island, and and we had graduate students from Columbia come and do a thorough examination, and the racial and demographics of that group track exactly the racial demographics of Staten Island. And also financially and age-wise, it's amazing how it's so pervasive throughout the community. But I want to say this to everyone here. If we lose time or use time talking about a negative aspect of whatever's being tried and debate whether the mistakes of the 90s should somehow impede this all-out, multifaceted approach to this problem, while we're sitting in this room doing that, here in the streets of Philadelphia, people are dying. In the bedrooms of Staten Island, people are dying. And so we should really just sort of open up and say, listen, until we get a handle on this problem, people are dying at a rate that we've never seen before in this country, and let not the sins of the past impede positive efforts to solve the problem.
Let's take another question. We have one back there.
Hi, I'm Rachel Meadows. I work for Councilwoman Sherelle Parker, and I have a question also related to the comprehensive user engagement sites, specifically the safe injection component of it, because from what I understand, the city wouldn't actually be running this site, you would like a private entity to do it. And my big question is, who's going to take on that liability? Because theoretically, they're going to be in violation of federal law. Our state attorney general has said he does not support safe injection sites. And we even have laws on the books here that say if a bartender or bar owner, they serve that one extra drink to someone who's visibly intoxicated, they go out, drive drunk, kill someone, the bar owner or whoever served them that drink can be held liable. So why would the same thing not apply here? If I understand the theory behind if they are injecting safely, hopefully they won't overdose, but what if they go out and then commit some crime or something like that? So who is going to take on that liability? That's my question.
So what we've said so far about comprehensive user engagement sites is we think Philadelphia could benefit from it. It could save people's lives. And now we're engaging in a process to think through all of the practical issues one would have to put in place to put one or more of these in place. We haven't worked out any of that yet. There are legal barriers. There's community concerns about where the location and where it would be. There's funding issues. There's who's going to operate those. I think those are all solvable. We don't have answers to any of them yet. There are people of goodwill who are potentially interested in operating sites like this. We think that there are people who may be of means who will be willing to donate funding for them to operate. As far as the legal issues, we'll just point out, if you were to read the drug paraphernalia laws, literally you'd say syringe exchange is illegal. Nonetheless, syringe exchange has saved many lives over decades in Philadelphia and is widely supported. I don't think the laws are in the books. They're designed to prevent someone like me from saving lives. So yes, there's lots of problems we need to work through, but I think we should continue to try to work through those problems in the attempt to save lives.
Next question, you pick. How about the front here?
Good morning. My name is Jesus Santiago, and I work
Sorry.
with the
We'll go to you
Philadelphia.
next.
I work with the Philadelphia Adult Probation and Parole Department. We see people with addiction every day. Now, these individuals, we try to get them into treatment facilities. We ask them to get into treatment facilities. The issue is that when they go, they have to test positive in order to get into the treatment facility. And some of these individuals have already stopped using, but still have the urge. Now, the issue comes when they have to go and use the drug so that they can get into the treatment facility.
Yeah.
Once they do test positive to get into the treatment facility, now they have to wait for an open bed. Instead of putting our money into opening safe injection sites, don't you think we should open up more treatment facilities where these individuals can actually have a bed and go straight into treatment instead of sitting out in the street waiting for a bed to open up, and now that they've used, they have that urge and they continue to use. By the time they get a bed, now they don't have the interest in going into treatment because they're so far into it.
If I can just respond. So I think what you're describing is just one of the sort of bureaucratic barriers that is impeding people's access into treatment, that you need to somehow prove that you are an addict in order to be able to qualify. That doesn't make a lot of sense. And people like you, I think, are potentially have great opportunities to be channeling folks into treatment. So that's one of the things I do think we need to solve. Just a couple other comments, and that is some people assume that treatment means inpatient treatment. And for some people, they may need inpatient treatment, but for a lot of people, they don't need to be staying over 24/7 in a facility. They can start as an outpatient. And there's a lot more opportunity for us to treat more people with outpatient treatment, which is far less expensive than inpatient treatment. So yes, we need to reduce those bureaucratic barriers, but there are a lot of ways to provide that treatment.
Mm-hmm. Let's go to the front.
I sure can. Good morning. I'm Darlene Miller, and I'm also from Philadelphia County Adult Probation and Parole. I just wanted to talk about briefly, right now we're dealing with a creation of a program. It's called the Police Assistant Diversion Program. We instituted that program as a result of a MacArthur grant. The reason why we instituted that program is to actually address the racial disparity within the arresting of offenders. And so what we've done is we've put it in a district where it's highly composed of African Americans. And what it does is individuals who would have been arrested because they are engaging in an illegal activity which kind of denotes that there's some kind of treatment services that could benefit them as opposed to being arrested. They're getting those services. I wanted to know if that's why you started your post-arrest pre-arraignment division, because it just causes me pause that we had to do it for African Americans in order to address racial disparity, as opposed to bringing services to everyone without arresting them.
And when did you start this?
We had a soft launch in December of 2017, and we just had our formal launch. We've had about 45 participants. One of the good things is we also have what we call social reform. And so you don't necessarily have to be arrested. You can actually go up to an officer and say that you are in need of assistance, and that officer can take you to, it's called PROACT. And we have certified recovery specialists who work with them. But there again, we're really not impacting as many people as we would like who would have been arrested, so that we can reduce the rate of incarceration for a situation where they really do need services. And again, it just caused me pause that we're doing it now to address racial disparity.
Yeah.
But is that why we
So no, we started the program really because what we were seeing was that the traditional models, drug treatment court, for instance, that have existed, were getting the individuals connected with treatment at a much later date through a process which included arrest, arraignment, conferences, motions, assessment. So it could be months before someone got into treatment. And they are, for possession only, usually leaving with some sort of letter, whether it's a misdemeanor, violation, or a felony, right? So we wanted to make it clear to people that we wanted to get people connected to treatment options more urgently. And so that's why we do it post-arrest, pre-arraignment. So within just a few hours of the arrest, you're having that discussion, you're talking to a peer mentor, and then you're issued, then you'll get a desk appearance ticket, and you've got 30 days, and if you engage, then the case is gone and records are sealed. In terms of the racial question, it's really throughout the district, the county, and so it provides an option for everyone, irrespective of where they're arrested. It's charge specific. It's possession only. If you're selling, it's not available to you. And I think that we started in January of 2017 on Martin Luther King Day, and we've had over 425 people have gotten the offer. 87% of those have accepted it, and those who have, 90%, have meaningfully engaged, and their records were sealed, and they're on some sort of better path, and the recidivism rate of them is just under 10%. And we measure recidivism by rearrest. So it's sort of across the district, it's helping, and we do it post-arrest. You know, the city of New York is one police department, and so it's hard to get a policy that would be just, say, for one district or one neighborhood. So we did it post-arrest and pre-arraignment, almost for an administrative ease, and to make it the same throughout. But now that program is being duplicated in Brooklyn, in Manhattan, the Bronx, and they've actually announced, and they're going to follow it. In Queens, we're consulting with them, and those are the 5 parts of New York City, to have it done as well. So it is a very good way to address that problem, and people who are possessing and suffer from addiction illness, it's a better way. So it was more about the urgency. The issue was what we were concerned about.
Mm-hmm. Let's go to the back there.
Good morning, Dave Rubin from the Children's Hospital of Philadelphia. I'm a general pediatrician. And, you know, we've heard a lot about the users and treatment today. We haven't heard a lot about the families who are impacted. And in particular, I mean, if you look at foster care rates nationwide, and even in our city, are going skyrocketing up. In only the 2 years that they've been measuring sort of the impact of substance abuse on placement decisions nationally, already up 7% in just that 2-year lens related to substance abuse, which I assume is related to the opiate epidemic. And there's 2 issues: our child welfare systems at the table in terms, and why or why not, in terms of placement decisions for children. And then the issue of kin. I mean, I think grandparents, aunts, and uncles are stepping up in ways that even more than they were a decade ago. There's a state bill right now that's passed the House, but I'm not sure it's been resourced at a level that's with a lens on the opiate epidemic and what kinship families need, because 25-1, most of those families have nothing to do with the child welfare system. They're making these decisions informally. So I wanted to talk about the children and about the kin a little bit and see what your thoughts were.
Who wants to take that?
I could talk a little bit about it. I can start us off. The foster care system is one that has been greatly affected by this crisis. And it's a key point. You know, we've talked about the providers, we've talked about the patients. We haven't talked a lot about the families, and children are affected, kin are affected, communities are affected. And obviously there are some challenges there, and foster care systems need more money and more individuals kind of helping. But one of the things that's key that we can back up and look at is, you know, how do we get more parents access to treatment? We talked about peer recovery coaches and their place in the criminal justice system and their place in the emergency room. We have done some work in Wisconsin, and they have done some pilot studies where they're placing peer recovery coaches in OBGYN offices. You know, so getting individuals, perhaps even before pregnancy occurs, you know, getting them to help address a substance use disorder. You know, it's really important that we do what we can to keep families together, right? That we get individuals treatment so we don't get to a point where foster care is needed. So we can back that system up and do a little bit more to improve it. But in the meantime, the foster care system is exceptionally hard hit and in need of resources to help address the problem.
Yeah, Doctor, your question is so spot on. I'm almost speechless, which doesn't happen so often, just thinking about that impact on the families and the rest of society. I mean, we see an incredible increase in the number of children who are born suffering from addiction illness as well, and they have to sort of go through a process of detoxification. We are seeing families torn apart by this crisis. We, in terms of one you know, measure with families and the impact is with domestic violence, 45% of the people who are either have had overdoses that we're dealing with, or people who come through our HOPE program, are also either defendants or victims of domestic violence. We've had 3 children who died from ingesting their parents' narcotics. We had one woman who was 8 months pregnant and she overdosed and died. We have another woman who was 5 months pregnant and she overdosed and now is being kept alive to see if the baby can be brought to term. We have parents who are being abused by their children who come in and steal their money and physically abuse them. And then as to the children in the system, more, you know, single parents are arrested, and then their parents have to go into the we call ACS, child welfare, to a point where I actually have someone from my office going to ACS every day with folders and dealing with these cases. So the impacts are very, very severe, and I don't think we've even begun to get a handle on what it's doing to the children and the kin, as you say. So I don't have any answers, but you're right. It is an incredible. Strong impact.
Let's go over there.
This is Mike Dahl with Broad Street Ministry, and we are one of the organizations on the ground that works with vulnerable populations. I just want to talk a little bit about that demand between the supply and the demand at the street level, because the people we're wrestling with that are addicted usually don't have a mailing address, don't have an ID, they don't know where they're going to sleep that night. They're dealing with hunger. They very often are wrestling with mental illness as well as addiction. And the level of trauma they're facing is so high that the idea of thinking that they're sitting there rationally thinking about how am I going to take that step towards recovery, do the paperwork, find the location of the place, get the transportation, is, you know, who would imagine that they're going to be able to handle that, all that complicated process on their own, to me is beyond me. I just want to ask, are there thoughts about putting more resources, more peer support, more counseling, more case management at the level at the street level, at the places where they're going, in places like Project Home or Prevention Point or Broad Street Ministry, or, and that's why I also believe queues are very effective, because they're meeting people where they're at and not expecting them to come to the system. Has that been a piece of the discussion?
Yeah, I think we have to go where people are. We have no other choice. It's a great question. And I think this is why it's particularly important to provide a host of services where people are. So not just, say, peer recovery specialists, people themselves in recovery from addiction, but treatment itself. So we're about to start 2 mobile treatment vans. They will be literally vans. They will offer treatment on demand. They're going to go to areas of the city hardest hit by the opioid epidemic. And importantly, you need to strip out just about every barrier that stands between a person and the treatment they will get on that mobile clinic. So you shouldn't have to bring your insurance card. You might not have an insurance card. You shouldn't have to bring an ID. You should have to bring yourself. And that's it. And that's the model we're going to go with. But because you're absolutely right. We can't let these bureaucratic barriers be the thing that prevents us from responding to the epidemic effectively and actually meeting people where they are.
But then how do you stay with people? Because if somebody comes to your van and they get in, but then who is there to help them through the next step and the next step and the next step?
So 2 points. One, I think this is yet another role that peers can play to start building that relationship of trust, to draw on their shared experience, and therefore to work to keep someone engaged in treatment. But this is also, another reason for which the quality of treatment is important. Sometimes when I talk to people in Baltimore about why they stopped going to treatment, they're very blunt. They'll say, because I felt like I was treated like a piece of trash. And so it's important not just that treatment is very available, but that it is delivered in a compassionate way, in a trauma-informed way, in a patient-centered way, that treats human beings as human beings and not as problems to be solved. And if we can make peers available, and if we can make sure that the treatment we're offering is humane and compassionate, then, we're not going to keep everyone, but we're going to help a lot of people.
I'll just add to that. For the people you're seeing, a lot of them are homeless, right? And that's the thing that's foremost on their mind is, well, can I have a roof over my head? And so Prevention Point has a respite where people can come in, basically right now, just walk in, then have a roof over their heads, and then while they're there, they can get in conversations around treatment. And now treatment is, we are beginning it at Prevention Point itself. So I completely agree. We've got to push the treatment right out to where the users are and try to find out ways that really, things that they want to draw them in, and having drawn them in, then we can begin the process. And our system is still too much based around our own needs rather than the user's needs.
Can I ask a quick follow-up question? And I hope this is not controversial, but to something that Dr. Rubin mentioned from CHOP. Does the topic of birth control ever come up when you're interacting with people who have a substance use problem and you have a moment of engagement with them where maybe a pregnancy at this moment in time could be prevented? Because that seems to be a terrible time to be pregnant.
Yeah, so I don't know, because I'm not a peer recovery specialist and I don't have those conversations. So all I can do is make a broader point, which is that good addiction treatment recognizes that addiction is just one part of someone's life. And so I think what's talked about with the patient is everything that is important to them and that matters to them, and that includes where they're going to stay. That includes how they might get a job if they want a job, or get a GED if that's something they need. And sure, it includes family planning as well. But I think it's important to, if we're going to have that conversation, important to have that conversation in a way that doesn't fall back on the sort of grossest of America's racist stereotypes.
No, of course not. But I mean, it seems like an important conversation to have, right? What's your take on that?
Yeah, I don't know whether those conversations are taking place now, but I agree that the way to have them take place is to provide those kind of wraparound services. Someone who is injecting several times a day, they've got to inject several times a day. That's going to be driving a lot of their decisions. We can somehow address that problem, make it easier for them to get, say, medication so they don't have withdrawal symptoms. Then you can open up to have a conversation around that as well as many other issues.
Okay, let's take another question. We have one in the back.
Hi, yes, my name is Lizette Lewis, and I'm a social worker.
Could you hold the mic a little closer? There you go.
I didn't want to be too loud.
That's good.
My name is Lizette Lewis. I'm a social work intern from Westchester University, and I'm actually interning in Kensington with a lot of constituents who are suffering from substance abuse. And I was just wondering, a lot of them that come into our facility, they're dealing with trauma, a lot of trauma issues like abuse and molestation, rape, and a lot of PTSD. So I was wondering, I heard about the MAT and the counseling, but the counseling, is it going to be geared towards any of the trauma-related issues that individuals are dealing with that contributes to their relapse, and how much is going to be contributed to that?
Yeah, if it's done right, yeah. I mean, absolutely. We talk about, this concept of trauma-informed care, right? We want to be looking at the experiences that brought the individual there. Those are triggers, right? There's experiences, there's bad experiences, the traumas that people have experienced need to be dealt with in order to get the most effective treatment. So absolutely, that is part of it, and it's part of the reason also that we look at this as a chronic relapsing disease, right? Sometimes the triggers come back or people remain in the same environment, and that's why it's so key, that we continue to reach out and continue to provide treatment that is compassionate. You mentioned compassion, how important that is in what we're doing.
Philadelphia has had a long-standing effort to be trauma-informed. So where does that stand in our city?
Yeah, so, the social service agencies, which are not mine, but the social service agencies I deal with, all are talking about having trauma-informed everything that they do. And absolutely, that is, a contributing factor to all this problem. I just want to point out that the reason we call it medication-assisted treatment is to say that it's not just a prescription for Suboxone. That is an assistant for the counseling and all the other helps that people can use to ultimately get their way to recovery. And we need to, make sure that the counseling really is paired with medication.
Where's the microphone? Here. Okay, so then we'll go to you. This gentleman has had his hand up in a while. So let's go here, or no? You ready?
Hi, good morning. My name's Megan. I'm working on an overdose prevention with people who are leaving our jail. My question is about keeping things like queues, low thresholds, and low barrier for people to get in. Specifically, what substances might be allowed to be used inside of a queues, and then separately, hearing about issues with pregnant women and people who are underage, since we know that queues can link people to treatment and other services, whether they'd be allowed to use the spaces.
Again, I give you sort of the same answer I gave earlier, and that is that all the really details of how a site like this would operate are yet to be worked out. I can just tell you in Vancouver that there's no barrier in terms of low threshold. You just walk in and you bring in your own substances and you use them on site. It has to be easy like that or it wouldn't be effective.
Let's go to you.
My name is Casey O'Donnell. I work for Impact Services in Kensington every day. So quick plug, Impact Services and NKCDC and Scattergood and LISC are actually putting together a trauma-informed neighbor engagement toolkit, so something that can actually be used by neighbors related to violence in the neighborhood and safety planning and emotion regulation actually on blocks. So if you want to talk about it, Zoe Van Oerstal is sitting next to me. So getting back to actually what works, so the Pew report today, which is wonderful, and others sort of interchangeably use the terms psychosocial therapy, behavioral interventions, counseling, and cognitive behavioral therapy, right? So we know that generally in other areas those things have much different effect sizes. So as it relates to medically assisted treatment, because this also says medically assisted treatment coupled with psychosocial therapy is the most effective, are we not looking at effect sizes? Are we looking at effect sizes of these different interventions and they're just not different, or are they not being considered at all? Does anyone know?
So that's a good question. When you look at the evidence that looks at medication-assisted treatment, unfortunately, when you look at the published reviews, it's not always clear, particularly from the behavioral health side, what that intervention was. They're always like, well, and we gave them counseling. But it's not clear whether it was group counseling or individual counseling or how often or what that service looked like. So while there's evidence that shows it's a key part of it, and again, medication-assisted treatment, we do need to know more about what types of models are working best. One of the things that organizations like Pew and others are doing in terms of the work that is being done in treatment and models and how we approach this is changing a bit. We're looking for opportunities to improve it, but we need to evaluate it when we're doing it. So people do need to do a better job of documenting exactly what that intervention is so we can learn a little bit more. But again, I'm not a social worker by training, but I know there are a number of different services. And we want to talk about tailoring to the needs of the patients, just like we need to have all 3 medications available, not just 1, not just 2, all 3, because it may differ which one for the patient. Mm-hmm. My sense is that for behavioral services, it's much the same, right? That what an individual patient needs may have some variability to it.
Mm-hmm. And also, much of this is still fairly new, since for so many years addiction treatment has taken place outside of the realm of healthcare, or what we thought of as healthcare. So we're just sort of catching up to even doing that research work.
Yeah, and I do think it's important, though, to keep in mind that this ambiguity, these unanswered questions, which are real, mm-hmm. The uncertainty is sort of bounded.
Yeah.
In the sense that, we have quite a large body of evidence testifying actually just to the efficacy of medication alone. And then we have additional evidence testifying to the greater efficacy of medication combined with this psychosocial support. And then the uncertainty is, okay, what does that support look like? What versions are better than others? And that's an important question, and we need to answer it more precisely than we've had. But it's also important to keep in mind that the uncertainty takes place within a space that we already know is way better than if someone were to get no option.
Yeah. Yep. Let's go to the back here.
My name is Felix Torres Colon. I'm with New Kensington CDC. It's pretty ironic that I speak right after Casey. I just wanted to raise, it's not really a question, but a comment. When we talk about cues, often you'll hear that what both the gentlemen said. There's all these studies that show that it's great. That's not resonating in our community, mm-hmm. right? Particularly studies from Vancouver that I've read, studies from Portugal, from places in Europe, all these are not resonating. Why aren't they resonating? Because we work in a community that historically could not trust the government that's supposed to serve it, right? And historically, all the studies have been to prove that something to the community's detriment was actually good for us. So the highway studies that wiped out neighborhoods, and you can go on and on. So I would suggest, or maybe you have ideas, on how you can have this conversation with a community that's scared, that's traumatized, that doesn't trust you, and get away from the scientific basis. I mean, I understand mm-hmm. why evidence-based stuff, but it's not resonating with our people. And these are people who get up and feed the homeless. These are people who get up and help addicts. But that particular approach is just a non-starter.
Yeah. Let me just say, we think those community conversations are extremely important. We're in the process of having those community conversations. We've held 4 community meetings across the city, including one in Kensington already. There will be more in the future to hear people's perspective on that. I think it's important in those conversations to bring out the scientific evidence. That is a key part of that. That's not the entire conversation. We also need to talk about, well, does it really work here? If so, how? All those sorts of things are really important. So I agree with you. We need to have those conversations. I'm certainly not going to ignore the scientific evidence elsewhere, because that is what is, to me, the starting point that says this can save lives here.
Evan, do you have?
Yeah, I also don't have a good answer. I think it's a great point. I think it's hard to figure out what resonates, particularly because this just hasn't been done in the United States. So it's not as if it's easy to draw on the experiences of cities like Philadelphia. I mean, it would be easier for Baltimore if Philadelphia did this, and then we could draw on their experiences.
We're hoping that Baltimore is going to go first.
Yeah. The one thing I would say is I think in general we could do a better job when talking about the opioid epidemic in taking a first personal perspective and talking about what things are like and how they look through the eyes of someone using drugs. I think this is true even when we talk about addiction as a disease. We talk about it as a disease, we talk about what people's brains look like, which is important because that science is illuminating. But we could also talk about what it feels like to wake up and be in withdrawal. And I have not experienced that personally, but it's pretty clear when you talk to a few people that it feels very bad, and that a great deal of drug use is just an effort to get well. And I think that leads us to the same conclusion that to which the brain science leads us. but you tell the story in a way that maybe just connects up with people's sort of empathy receptors a little bit more effectively.
Let's take another question over here.
Oh, thanks. I'm a licensed clinical social worker, so I have done the psychotherapy with folks who are receiving MAT, and I'm glad that somebody introduced themselves as, you know, having time, because the big disappointment is, you know, the view I think that NA has. NA is a great resource. It's free. It's available every day. And I think maybe my concern is that they're not up to speed on how we're treating addiction. And this view that, you know, you're not quote unquote sober or abstinent. But the reality is, like, who cares? You're alive. And as a psychotherapist, I can't do it on my own. As a doctor, you can't do it all on your own. But NA is like the 12-step program really helps people whose lives have just blown up to help repair their lives. So it would just be great. It's just a comment. I don't know if there's a question in here, but you know, I unfortunately have had to say to patients, go, but I don't know that you need to volunteer, you know, that you're receiving MAT. So, and you know, that's a conundrum.
Just gonna, yeah. Any comments on that?
Couldn't agree more.
Yeah. Yeah. Let's take two more questions. We have one here.
Okay. Hi, I'm Spencer Rand, and I work at Temple Law School's Legal Aid Office. I'm very happy to hear you all talking about addiction illness as opposed to like addiction personal failure or something like that. And the reason is that one of the problems that I see when I represent clients is that they don't have any resources. And they don't have resources because for 20 years SSI has said you can't apply and have an addiction. You can't get housing because the housing authority is going to turn you away because you have this sort of problem. And I'm wondering whether there's another front that should be sort of considered, which is like, what sort of resources can you get to people? Should you have Baltimore or Philadelphia saying, you know, we need to make sure that people who have addiction have housing. We need to make sure that there's some sort of income coming in so they actually can get to some treatment and actually have a life where they can do this. I mean, I love the idea of the diversion program that doesn't give somebody a record necessarily. On the other hand, if they fail, they end up with a record, right? If they ended that sort of diversion, I would imagine if they fail and then they have to go to court, then they end up with a record, and that is a problem that's going to make it so they're not going to have a job. So they're not going to be able to actually get to use this help. So my question really is there another way to think about this is have to get resources in the hands of people so they can take advantage of the stuff that you're hoping to do?
So, and it's a very good point. In our program, where people are sent from the precinct within 7 days, they have to go for an assessment, and that assessment really speaks to your point that maybe it's outpatient, maybe it's housing, maybe it's other areas of economic literacy, maybe it's some other type of programming connection, right? And so we don't mandate it has to be treatment, inpatient, outpatient. Some people do, a good percentage, and especially converting misdemeanor arrests into that type of direction is a very positive thing. But we agree that there are other attendant issues, and if they can assess that and address that with the person that helps them find a different course, then we do support that. Yes, if someone does accept the program and then sort of drops out, if you will, then their case is reinstated. It will get docketed, but then they will get another chance. We don't say you failed once and forget it. We've identified them as a population that really should use this, and as long as they don't get rearrested for a violent crime, then we'll keep trying to work them through it. But the best part of it is that there's no record of the arrest and no docketing in court. So yes, it would be then docketed, but that record can also be sealed as well. So
if I could, and I know we're short on time, but just one other quick comment. Businesses, we're seeing more businesses and chambers of commerce get engaged in this, right? Because one of the biggest costs of this is lost productivity. So they have something to gain in terms of ensuring that there is treatment access within their communities and that people get care. But then we're also seeing, large employers in areas, work to find job opportunities for individuals who have had a substance use disorder, who are in treatment, who may have a record, a criminal justice record, because these people are employable. I mean, there are things that they can do, and the businesses need the assistance. And so, training organizations and employers to have a better understanding of the disease and how it can be managed really, and bringing those groups into this discussion is also key.
All right, let's take one last question.
Thank you all very much for a wonderful presentation. I'm Barbara Schindler, and I am the medical director, a psychiatrist at Drexel University College of Medicine for an addiction treatment program for women. And one of the things that we think about is the physical pain that people get prescribed Percocets for, get opioids for, and often forget that what continues the use of those substances is emotional pain. And very often, and certainly in the patients that I see, there's a very high rate of co-occurring psychiatric disorders. And I wanted to raise kind of the question, or get people to think about whether we should be talking about expanding the concept of medication-assisted treatment to include psychiatric medication.
So that actually is part of how we look at treatment, right? And it is more complex to manage someone with a serious mental illness and a substance use disorder, but clinicians are trained to screen for that and to manage both. You probably don't hear enough about it. There's perhaps not enough of it going on in terms of doing the screening to identify a serious mental illness. So we do need more emphasis on it. But in theory, it is part of the larger picture.
Anybody
We need
else?
to manage both.
Yeah. Any thoughts on that? Or
Certainly, yeah, the co-occurring disorders are clearly a part of that. So I'll defer to other experts as to what's the best way to manage that.
all right. Okay, I think we're going to wrap things up. We have some final remarks coming our way. And thank you all for the great questions and for the input.
Well, thank you, Micah. That was really terrific. And by way of introduction, my name is Fraserita Klassen, and I'm the Vice President at Pew. I oversee Pew's Philadelphia program work. On behalf of Pew, I want to again thank our distinguished panel for being here today. Philadelphia Health Commissioner Thomas Farley, Evan Burley of the Baltimore City Health Department, my dear colleague Cynthia Riley, thank you so much for being here. The District Attorney from Richmond County, Staten Island, the Bronx is my hometown, Michael McMahon, and Mike, who is from WHYY's The Pulse. So thank you for a terrific job to all of you.
Thank you.
And I just want to say we are grateful to each of you for being here this morning. You all had terrific questions and comments and feedback for our panelists. I want to thank those out there in Twitter land for joining us in this conversation. It was an important and sobering conversation we had this morning. I appreciated the reminder from each of our panelists this morning to remember that there's no easy answer to what is a complex and difficult problem. Whether you work in healthcare, public safety, law, academia, human services, or the public sector, or you're simply a concerned citizen who are worried about your neighbors and family members, I hope that you found something useful in the conversation we had this morning. If you would like more information on Pew's research, which Cindy described this morning, on substance abuse prevention and treatment, or Pew's research on Philadelphia, please visit pewtrust.org. You can go to /State of the City, pewtrust.org/State of the City for more work, for more information on the work that Larry Eichel and his colleagues are doing. I have to take a moment to thank the other terrific colleagues from Pew who worked on putting this event together. They were tireless and fearless and really very thoughtful about pulling this all together, and really thought about what are the questions each of you might be interested in and want more answers about, and we're really thoughtful about pulling this important panel together. So Thank you for joining us. I'm a little bleary-eyed. I didn't get back to Philadelphia till very late last night, so sorry if I'm stumbling a bit. But what I really want to say is please feel free to stay and mingle. We have some more time. I think we might have some more food out in the hallway if that will stimulate your interest. But our panel will be here for a little bit longer and be available to answer additional questions you might have. So thank you all for coming.
Thank you.